Hello everyone, thank you for watching my presentation about bipolar disorder and non-specific low back pain. First of all, what is bipolar disorder? So it refers to a group of affective disorders which together are characterized by depressive and manic or hypomanic episodes. In UK, 1.3 million people are affected. And in terms of diagnosis, it can take about 5 to 10 years to diagnose because it is often misdiagnosed with other mental disorders such as depression, hyperactivity, or ADHD. There are four different types of bipolar disorder. Type 1, where the patient experiences one or more episodes of manic episode associated, and one episode needs to last at least 7 days to diagnose the illness. Type 2, where the patient experiences both state but depressive episodes are dominant. Cyclothymic disorder, where the patient experiences at least for 2 years of mild depressive and manic episodes. And last one, bipolar disorder not otherwise specified, where the patient experiences shorter hypomanic and depressive episodes that vary rapidly. In terms of etiology and prevalence, so bipolar disorder is not well understood, but however, we can observe different causes. In terms of biological causes, genetic with the implication of chromosomes, family history. If one parent is affected, the chance to get the disease increased of 10%, and if two parents, the chance increase of 40%. As well, chemical hormonal imbalance in the brain due to the drop in noradrenaline and serotonin levels and an increase in cortisol levels contribute potentially to the onset of a depressive episode. And to finish, the study of EBAR on brain have shown brain changes such as a reduced cortical thickening in some bones, but furthermore, more study needs to be done. We can observe as well some environmental causes, such as life events, so for example, breakdown of a relationship or maltreatment, and as well the stress. In terms of prevalence, the average age of onset is 25 years old, but it can occur in the teens. Men and women are affected equally. In terms of symptoms, we can differentiate one state to the other. So about depressive episode, the patient can experience an increased need for sleep, an extreme sadness, feeling of worthlessness, suicidal thoughts, change in appetite, lethargy, and some memory and or concentration alteration. During the manic episode, the patient can experience some risk behavior, so uncontrolled spending of money, gaming, practicing unprotected sex, some distractibility as well, and some unlimited thoughts with unachievable projects and no regard for consequences, a decreased need for sleep, an increased self-esteem, high energy levels. They can be logorrheic as well, and they can experience some delusion of grandeur, which can be associated with delusion of persecution and mysticism. So, for example, the patient can thought God gave them a mission or feeling persecuted by the government. In terms of treatment, there is no treatment, no cure. It is only symptoms management. Medicamentouse treatment focus on stabilization of acute episode in order to bring patient in euthemic mood. And the study of Vasquez shown some potential innovative treatment for BD, considering ketamine or anti-inflammatory, etc. But however, more research needs to be done. In terms of medication, the patient can often have some mood stabilizer. The most common is a lithium, and it acts on manic episodes specifically. They can have as well antidepressant to act on the depressive state, but it can trigger manic episode. They can have antipsychotic to manage psychosis and avoid disillusion, paranoia. Benzodiazepine used as tranquilizers, anticonvulsant used to calm hyperactivity. In terms of psychological treatment, talk therapy can be good to learn how to recognize and manage signs of an episode, and advise how to manage social interaction, relationship depression. And as well, it can be very good to give some nice lifestyle advice, which are cited above. In terms of risk and protective factors, so we can observe numerous risk factors. So genetics again. So some studies have shown link between bipolar disorder, twins, and schizophrenia, as well as some prenatal and perinatal factors, childhood trauma abuse, psychological stress such as postnatal depression, life events again, stimulant misuse such as cannabis, opioids, and as well some comorbidities such as obesity, anxiety, ADHD, etc. As well, some seasonal factors have been observed, and it can thought to be a trigger for depression and mania by affecting the pineal gland. In terms of protective factors, they are not direct, but some communication in family can be good. As well, an early diagnosis of bipolar disorder can be good for symptoms management to prevent from suicide, because patients with bipolar disorder increase their risk of suicide by 20 times, and it is good as well to avoid some risk behaviors. And as well, stress management can play a role in the development of the illness. Now we're going to talk about non-specific low back pain and bipolar disorder. So what is non-specific low back pain? It is a low back pain not attributable to a recognizable non-specific pathology. So it is very important to rule out any underlying pathologies for the diagnosis. What are the links between BD and non-specific low back pain? In terms of psychological factors, limited treatment outcome due to negative mental state. As well, some pain intensity needs to be considered due to mental state change in perception. As well, the impact of pain on mental health can change, so it is a very vicious circle. And the study of NANI have shown the effects of childhood trauma can impact the treatment outcome in depression. And in terms of physiological factor, negative mental health triggers pain stimuli. In terms of OPS and osteopathic management, it is important to gain informed consent of the patient to respond to the OPS A1, to be conscious of our limits of competence to respond to the OPS B2, being aware of potential prognosis of treatment due to BD to respond to the OPS C1, to communicate with other healthcare practitioners to optimize patient care in reference to OPS D10, sorry. In terms of osteopathic management, because we have an holistic approach, so we consider the patient in terms of biology, sociology, and as well psychologic. Parson said mind and body are connected, so we have to take it in consideration again. As well, some manual therapy has a positive outcome on pain level. And cranial osteopathy can have some benefits regarding sleep, stress, energy level, mood changes, and as well, it can affect beneficially the low back pain. And to finish, some referral and liaison. So it is important to refer the patient to GP if there is a suspicion of bipolar disorder, or for medication checkup. As well, it can be good to refer patient for cognitive behavioral therapy or family therapy, and they no need of a GP referral, but the disadvantage is the patient needs to pay for each consultation. And as well, the patient can find a free support on the Bipolar UK website to book a phone consultation or using their forum. And there is also a page for urgent needs. And in terms of liaison, a continuous liaison with other healthcare practitioners is essential for best care of patients. Thank you very much. You can see my reference in the last page. Bye.